What our students will actually be doing this is a health center in Alappuzha. This is, again, if you just go up that main road, this is a health center, and this in fact is a microfinance center. And so one of the things that we're thinking about, in fact Tim and I have a meeting later on this afternoon, is to actually look at how microfinance and these sorts of what Michael Sheridan calls social innovation strategies may actually have health outcomes. And so in some sense, I think the next stage in this work is going to be looking at the neurobiology of public finance. Is to look at, do these sorts of public finance interventions have epigenetic or neuroendocrine or neuroimmunological effects that might do disease vulnerability. And so in some sense, this is coming right back to this idea that if wealth is health, if you do interventions that can potentially increase wealth, can you also understand the underlying mechanisms that can decrease disease vulnerability? And so that, I think, is going to be the next stage of the research that is going to come out of our summer trip. The other thing that's going to come out of our summer trip are a group of 14 students, done medium well, since it is the height of May. So I'd like to end my talk with what is another one of my really, really favorite studies. This is Jeffrey Rose's study from the late, great Jeffrey Rose, researcher and teacher extraordinaire, who made most of his career at the London School of Hygiene and Tropical Medicine. Rose published a paper in 1992, where he talked, called Sick Individual Sick Populations, where he talked about this idea that this is the distribution of systolic blood pressure among London civil servants, among Whitehall. These are from the Whitehall studies. This is the distribution of blood pressure among tribesmen of the Masai Mara, among Kenyan tribesmen. Now, what we've done primarily in medicine is that we've actually taken these people and we've tried to pull them back. So essentially, we've tried to pull this distribution in so that all those people who are showing a 200 systolic blood pressure are actually showing a 140 blood pressure, right? So we've done something like this. But what we ought to be doing in public health is actually not this. We ought to be doing this. In other words, we ought to be taking this population and we ought to be shifting the determinants and the distribution of this population to the left so that the range of blood pressure among London civil servants resembles that of the tribesmen of the Masai Mara. And the other important thing, as Rose taught us, is that the determinants of blood pressure here are actually not going to be the determinants of blood pressure here. The stuff that you have to do in order to pull someone's tail in, like prescribing antihypertensive medications, is not going to work if you're trying to shift the population distribution of disease to the left. That involves things like salt restriction and other kinds of things. So what we have failed in public mental health is we have had enormous successes in this leg of the thing, right? We've had advances in neurobiology, in neuroscience, we've applied neuroscience, we've sacrificed more mice than any plague epidemic has in the history of the universe. But we haven't changed the distributions of disease. We still have about 1% of our population suffering from schizophrenia. We still have about 14% of our population suffering from affective disorder. We've completely failed in adopting a public health approach to mental health. And I think if we can knock that off, I think then those of us who are mental health services researchers can happily retire from academia and do private practice. I stand on the shoulders of many giants. I'd like to acknowledge my funding agencies. I have a national and international set of collaborators and consultants who keep me on the straight and narrow. And I have a superb research assistant who generates my slides for me, who's awesome. If there is anything that I can assist with that we cannot get done in the next 10 minutes in terms of questions, this is where I can be reached. Thank you for your attention.
You're an excellent forecaster, I'll say that.
5 minutes over where I thought I would end.
That's because my question's at the middle. So, yes, Bill.
I'll ask the obvious question because I want to make sure I hear an answer to it sooner or later, and that is that, so one of your conclusions is pretty fascinating about that Medicaid exacerbates race and ethnic differences. I'm wondering about the Ryan proposal and what implications that would have for that conclusion.
I understand that this is being televised on YouTube.
Yeah, right.
And I have no desire to put myself in libellous situations or use what is known as unparliamentary language. I'm actually not a major fan of Representative Ryan's proposals for a variety of reasons. I think we don't really have an alternative to assuring health status for these children. I can certainly see the point that he's making for adult Medicaid beneficiaries. But when you think about who is actually enrolled onto Medicaid, Medicaid is fundamentally a program for children and pregnant women. It's basically, that's what it is. In terms of who is actually on Medicaid. If you're an adult male, it's virtually impossible to get onto Medicaid. There is a small age blind disabled category, but numerically it's actually a very, very small category. Medicaid, therefore, is fundamentally a public health program. It supports early intervention and screening for children, and it actually supports the sorts of things that we want to provide to pregnant women so that they can actually have an uneventful pregnancy and can be assured of having a very, very good child health outcome, at least a neonatal or infant health outcome. That is exactly the sort of stuff that we ought to be doing. That is really core public health, and there isn't a market for that. There has never been a market in the history of health insurance for public health interventions, and there is very little alternative to strong governmental intervention. There is complete market failure when it comes to public health. So Medicaid is the single largest guarantor of the nation's public health for the most vulnerable of its populations, and I think it's a colossal mistake to mess with Medicaid.
Can I have a follow-on question? When I look at the impact of the rapid growth in Medicaid expenditures on state budgets, and sees how often it results in a squeeze on education funds, what's your alternative to Congressman Ryan's brainstorm?
And it's actually, I think, a fair question of which I think is predicated upon the fact that if a slice of the pie gets larger and you hold the slice of the pie constant, another slice of the pie is going to get narrower. And I think we all know that states basically spend money only on 4 things. They spend money on Medicaid, on transportation, on education, and corrections. And since most of the other things are sort of fairly well protected, the only other give that occurs is on education. I actually think that, I may be a Marxist here, but I actually think that it's not a bad idea to maybe raise taxes. I actually think that there is a case to be made for increased public investments and increased public spending on Medicaid, on education, and on those things that I guess would increase health capital, would increase human capital, and would actually give us a fighting chance of being very, very competitive in the rest of the world. So
as a side note, I should point out that some of the students of this group have pointed to incredible ways in the correction.
Yeah. Yeah.
So this is where a lot of money can be saved if we did our correction system a little different. We have 2 studies going on that have clearly shown that this is a place where we could really cut costs.
Medicaid fraud and abuse studies basically suggest that only about 4 to 5% of Medicaid expenditures are probably the result of fraud and abuse at state levels. So this is certainly, there is certainly scope to trim fraud and abuse when it comes to Medicaid. Estimates of Medicare fraud and abuse are somewhat higher; they're in the order of 7 to 9%. But it's not a. So I oftentimes hear that, just like in corrections, which I should not comment on since that is not an area that I know well, but in Medicaid, I oftentimes hear that if we only reduce fraud and abuse, we'd actually solve the problem. Actually, we won't. We'll solve a relatively small fraction of the problem. The major reason, of course, why Medicaid costs are going up is because medical cost inflation is outstripping general cost inflation between 2 and 3 times that. And I think that is too big of a problem for Medicaid to solve on its own. And there are really a variety of reasons why why medical cost inflation is actually occurring. And there are like treatises on this. And many of those things you actually cannot change unless you dramatically change the practice patterns that American physicians practice. And so as someone who's been double trained, actually been triple trained in Britain, in India, and in the United States, I actually see how we practice medicine in the United States compared to how we practice it in India and the UK. And we certainly practice a very, very expensive form of medicine. Unfortunately, that doesn't guarantee us the sort of health outcomes that we think it should, right? Because if you read the World Health Organization statistics, France is the country that is supposed to have the best outcomes for its health system, at a spending that is 5.6% to, I think now it's like 6.4% of GDP.
Yeah, great talk, Ramesh. Enjoyed it. I wanted to, following up on that earlier question about the disparities, and a couple times you mentioned the carve-outs as a big issue leading to that and causing, relating to the problem. So if you could dive into that a little further and talk a little bit more about what exactly is going on with the carve-outs. Is it related to, it's well known in the health economics literature and the RAND health insurance experiments that the largest elasticities come from mental health. Is that what's partly causing it, or am I on the wrong path?
So, I think Medicaid should be like Medicare, where we do not carve out behavioral health services, where we offer, where we do, it's a soft quasi-carve out, but basically, we don't really have the sort of a hard subcontract that goes out for behavioral health services. And I think what is going on is that we've actually developed what is in effect a caste system within Medicaid. We effectively are sending groups of Medicaid beneficiaries to a certain class of provider, and while we are sending other Medicare beneficiaries to another class of provider. And and not only have we exacerbated this class system between Medicaid and Medicare, we have exacerbated this caste system on the behavioral health versus the physical health side. And so if you attend any of these workshops that Missouri Medicaid does, and they actually do it at our school, and you hear all these people, and I actually review a lot of those referral forms that actually show up in Jeff City, and you see these astounding documentation standards, and you realize that these individuals actually specialize in Medicaid. They only see children in child welfare. They have no opportunities for broader professional socialization. And we're actually doing them a disservice because we're not allowing them to improve their skills by expanding their client repertoire. And so we're ossifying people into these groups. And I think that is what carve-outs have essentially resulted in, which I think is very destructive for mental health practice in the state.
Any other questions? I would like to, if you could give us, I want to kind of push on this same, what is it that the carve-out system does? If you could, you seem to have a clear understanding, since we do institutions here that really appreciate understanding the kind of the technicalities of this policy.
So what is, how does it actually work in practice?
Yes.
So the easiest way, I think, to explain it is if you were to look at your insurance cards, you probably call one 1-800 number for your physical health needs, but if you have a mental health need, you probably call another 1-800 number. And in Washington University, that is how our employer-sponsored health insurance system is organized, because there are only about 4 or 5 major mental health managers in this country, like Magellan and United Behavioral Health, and they actually basically have it's in a sense it's actually a monopoly on the mental health market for employer-sponsored health insurance. What that results in is that it actually ties you in to certain groups and certain providers and certain health plans. Now, the reason why the employer-sponsored health insurance market for mental health is not that bad is because, firstly, they pay more, and individuals who are seeking mental health services have an ability to navigate the system better. And plus we have employee assistance programs, which are designed to act as a sort of a gateway, as a navigator, if you will, between an individual who seeks services for a behavioral health condition and the system that is designed to provide him or her with services for his or her behavioral health condition. Now, Medicaid has solved in that sense of that monopolistic problem by doing something what that they call in the statute as an at-will So Missouri is an at-will state. Anyone who is a licensed professional can bill Missouri Medicaid for services. You don't have to be on a panel, you don't have to join up for services. Anyone can do it. So those of you who are licensed professional can simply write, and Medicaid will give you a Medicaid provider ID number, and you see your patient and you bill, and they'll deposit their money in your checking account. It's actually seamless. They do a phenomenally good job of billing. So they've solved some problems, but what they have not been able to do is that because they have essentially sequestered behavioral health providers who see these disadvantaged populations, and because we have never really had a Medicaid provider increase since the early 80s. I want to say 82 is when psychologists and social workers last had a provider increase. We did have a physician provider increase about 3 years ago. So since we've sort of frozen that, it's essentially created, in a sense, a self-selection of individuals into the Medicaid system. And so the kinds of individuals who are getting into Medicaid are the individuals who probably might not be able to compete out in the private behavioral health market. In Missouri, we've done certain other really asinine things. So for example, in Missouri, you can actually be, if you're a licensed professional counselor, right, you cannot see adults, but you can see kids. Because I think we tend to assume that the mental health needs of kids are less complex than that of adults, whereas we probably know that the reverse is the case. So there are some structural problems in the way in which we design our Medicaid program, which I think contributes to these challenges. So it's a very long-winded answer, I'm sorry to say.
A small question.
Yeah.
On the pharmaceuticals that are used in mental health, the last time I checked, which is a while ago, Missouri, but I'm not sure if was I checking Medicare or Medicaid, the formulary was much more liberal than, say, the Blue Cross formulary in terms of brand names. Blue Cross pretty much requires you to use generics. And so if you were paying regular insurance, you were forced to use generics, but if you want, was it Medicare or Medicaid?
Medicare.
It's Medicare mostly.
You can use a brand, you can use brands. And I could never figure out the rationale. I can understand the pressures, but
I think you figured it out.
It's so if
Part D has fixed this a little bit, but anyways, go ahead.
So my understanding of the Medicare marketplace is because they're worried about monopsony. They're worried about Medicare exerting monopsony, which is why Medicare is explicitly forbidden from establishing formularies and doing aggressive price negotiations, and in the absence of price control. So that is my understanding of how the Medicare marketplace works. Medicaid, of course, does also has a monopsonistic effect on mental health psychotropic drug purchasing, because Medicaid is the single largest provider of mental health services. It's second to private insurance, of course, but for this population, it is the single largest provider. So there are challenges there.
Thank you very much.
Thank you.